participants can answer, if you have any questions, they can answer in the chat box.
Sure, I'll do that.
And I'll be there towards the end to sort of ask the Q&A together. I think you've done this before, right? So you sort of know.
Yeah, I have done it earlier. I have included a lot of slides, so we'll stop whenever the time ends.
Yeah, you take your time, don't hurry up. If there are enough slides, we can just do a part 2, a few months ahead.
Okay.
Or any sort of, whenever Saturday, whichever Saturday you are comfortable with. We can just do a part 1 and then a part 2, rather than hurrying and quickly finish.
No, that causes a lot of confusion.
Yeah. I mean, time is not a constraint here.
Okay. Otherwise, it is for 1 hour.
Yeah, it's for 1 hour. So usually, there'll be some Q&A, so it might end up going beyond the hour. If you stop at 8, usually at least 10 to 15 minutes of Q&A happen.
Right.
And now free, or you can stop at 7:50 or 8 and take the Q&A. And we can do the rest of it in a part 2 session.
Sure.
So I will see you in Isgar soon, though.
Yeah, really looking forward. जैसे वो हैरी पॉटर में सब हॉगवर्ट्स के लिए वेट कर रहे होते हैं ना. It's the same thing for us. We are all waiting the entire year to see each other at Isgar.
This will be great. And this time, I mean, the program looks great,
Yeah.
Good faculty.
International faculty.
Yeah. So it should be fun. I'll try to drop in Max as well if possible.
Yeah, please come. When are you coming, on Friday or Thursday?
So I'll probably join on Saturday.
Okay.
Friday, I'm not sure. But Saturday, Sunday, I'll be there the entire time.
Yeah, so whenever you have time, do come to Max.
Yeah. Amit, I was just talking with Amit and he was telling me about the newer things happening in Max. So I don't know how far it is from the conference venue, so I don't know. Hope I can, but let's see.
On Sunday, it will not take very long. In Saturday, Sunday, both days, there will not be much traffic.
Okay. So it is 7 o'clock. So what I will do is I will just first introduce you. Everyone, this is Akshay Baheti and welcome to today's webinar. Can you see the screen?
No.
Oh, okay, hold on. That's what I thought. Yeah, okay.
Yes, now I can see.
Hello everyone, this is Akshay Baheti and welcome to today's webinar, and I'm so glad to have back with us Dr. Ruchi Rastogi. Dr. Ruchi is Associate Director in the Department of Radiology at Max Super Specialty Hospital, Saket, and she focuses on body imaging, especially hepatobiliary and liver transplant imaging. And if you look at the cases, that the collection that she has, it's just phenomenal. The variety of cases, and the way she diagnoses them is just extraordinary. So I'm really looking forward to this session. Ruchi Madam has also written a chapter in the Sutton's textbook on liver. So do definitely have a look at that. And she's going to speak on mixed bag hepatobiliary and pancreatic cases, case-based discussion. So before handing it over to her, just to let you know, tomorrow Dr. Nilofer from MGH Boston, Harvard University, will be taking GI and GU-based case review. So over the weekend, essentially, we have covered, everything in the abdomen. These are our webinars, which are open access as of now. These are our handles to follow. This is the ILD course, so do register for that if you're interested. And this is an interesting, AI webinar happening, but this is only on practical AI, no theory, only on things which you can actually use in the reporting room right now. So if you're interested, do register for that as well. All right, so with that, I'm going to stop my share and hand it over to Madam.
Thank you, Dr. Akshay. It's always a very great pleasure to come to REF webinars, and the kind of participation you have is very nice. So now we are going to discuss some of the interesting hepatobiliary teasers. It will be a case-based discussion. So over next 1 hour or so, we'll see some of the uncommon lesions with typical imaging features, some of the uncommon lesions with atypical imaging features, some of the common lesions with atypical imaging features. And because this is a brain teaser session, so we'll include the common lesions with typical imaging features in the form of a quiz at the end of the session. So this, I always thought one should have the disclosure of number of slides. So in this we have 155 slides. I'll try to cover only as much as we can do justice with. I have made 7 case capsules and I have 10 quiz cases. So now let us come to the first case capsule. This was a young 18-year-old male with no known comorbidities. He presented with vague symptoms of tiredness, weakness, and dull aching pain for about a month duration. There was unintentional weight loss of 4 kg with normal appetite. And on examination, there was no pallor, icterus. Per abdominal examination revealed a smooth mass of about 10 centimeters. So these are the MR images. In this, we can see on T2-weighted image, there is a large lobulated mass, which is almost occupying the entire right lobe of liver. There is another smaller mass in the left lateral segment. These are showing mildly hyperintense on T2-weighted images with some areas of heterogeneity. There is hypointense signal on T1. In phase and opposed phase do not show any intralesional fat. Marked diffusion hyperintensity, ADC hypointense signal. In the abdomen below, there were few borderline enlarged para-aortic and intra-aortocaval lymph nodes with sub-centimetric short axis diameter. On post-contrast images, the mass is relatively hypoenhancing compared to the remaining liver parenchyma on all the images. There is mild enhancement which is progressive in the subsequent venous phase images. There are these few enhancing strands within the lesion. And these are the 2-hour delayed hepatobiliary phase images in which we can see that the mass is showing hypoenhancement. And this is the contrast in GB, which shows that this is an adequate timed hepatobiliary phase image. So with this imaging picture, we can think of entities like metastasis, inflammatory pseudotumor, lymphoma. And this is not a classical picture of cholangiocarcinoma and HCC, but because these are the common liver tumors, so we have just included in the list of differential diagnosis. So just to exclude these last 2 entities, we did lab tumor markers. The alpha-fetoprotein, PIFCA, CA19-9 were within normal limits. So the cholangiocarcinoma and HCC are less likely. Then the patient had a PET CT. In the PET CT, the liver masses are showing high FDG avidity. And besides the liver masses, there were few focal areas of FDG avidity in multiple bones. On the corresponding CT images, there was no huge area of destruction, but some permeative area of destruction and some lytic areas on the corresponding CT images. So with this kind of imaging picture, diagnosis of hepatic lymphoma was made, which was subsequently proved on histopath. So in lymphoma, classically the masses are minimally or non-enhancing on all the faces, and sometimes one may see some vascular channels coursing through the lesion, which is also known as vessel penetration sign. Sometimes the masses may show a rim-like enhancement and a central non-enhancing area with a target appearance, which is, sorry, I just... How do I go back?
Sorry, what happened, madam?
So I can't see my slides.
Oh, really? Why don't you stop share and try sharing again?
Okay, I'll just do that. Okay. So, I have to remove.
Can you see them now?
Yeah. So sometimes the lymphoma may present as solitary mass or multiple nodular lesions, diffuse infiltration, and in some cases it may present with periportal soft tissue mass. So when we talk about periportal soft tissue mass, I just want to show another case which we saw a few days back. And this was a young child who had presented to the liver team with features of liver failure. And in this, we can see that the liver is quite distorted and lobulated in shape. And there are these abnormal soft tissue densities in the periportal area, which are relatively hypoenhancing on post-contrast images. The patient also had a MRI, which showed that these periportal soft tissue areas show mildly T2 hyperintense signal, T1 hypointensity, mild diffusion hyperintensity, and ADC hypointensity. So this also was proved as a case of periportal lymphoma. Now, there are a few other differentials when there is picture like this. There may be some biliary tumors like cholangiocarcinoma, which may present in the periportal space, chloroma, lymphoma, as we have seen. Sometimes Langerhans cell histiocytosis may also present with these periportal masses. Nerve sheath tumors may be more homogeneously hypointense, leiomyosarcoma, and uncommonly some mesenchymal tumors and inflammatory pseudotumor, Kaposi sarcoma, may also have this kind of picture. So whenever we diagnose a case of lymphoma, it is very important to classify it, whether it is a primary or a secondary lymphoma, and there are various clinical and imaging features which help in this classification. So by definition, primary lymphoma is the one which is confined, primary hepatic lymphoma, which is confined to the liver and perihepatic nodal sites without any distant nodal involvement at the time of presentation. While secondary lymphoma secondarily affects the liver, so there are other areas of involvement as well. Incidence of secondary is much more than primary. Primary may be associated with some viral infections like EBV, hepatitis B, C, HIV, and cirrhosis. The presenting symptoms are non-specific in primary, maybe right upper quadrant pain or sometimes jaundice, especially when there is biliary obstruction, which is not a very common feature with lymphoma. While secondary classically presents with the B symptoms of lymphoma like fever, night sweats, and weight loss. Bone marrow involvement is more of a feature of secondary. The lesion distribution in primary is usually solitary discrete lesion, while secondary present as multifocal lesions or diffuse involvement. The dominant mass is usually present in primary, not in secondary, and morphology is more heterogeneous in primary than secondary. Splenic lesions are more common in secondary, and generalized lymphadenopathy are also more common in secondary. So the treatment of both these types, the primary and secondary hepatic lymphoma, differ. So it is important to think about it. Now, as a companion case, another imaging differential of this kind of case, this was an elderly man with abdominal pain, and the liver mass was initially detected on ultrasound. On post-contrast CT images, we can see that the liver is non-cirrhotic and there is a ill-defined hypodense mass in the left lobe, which is showing mild post-contrast enhancement, more in the center, and there is some peripheral hypoenhancing areas. Now, it is important to note that there is no upstream dilatation, despite the location of mass along the course of portal radicals. In the delayed post-contrast CT images, the mass is still heterogeneously hyper-enhancing compared to the remaining liver parenchyma with patchy hypoenhancing areas. So this was proved to be a case of inflammatory pseudotumor, IgG4-related pseudotumor. This is a close mimic of lymphoma. It may present as a well-defined parenchymal mass mimicking intrahepatic cholangiocarcinoma. It may be hypoenhancing or hyperenhancing in different situations, and histopathologically, there are two classical types: the fibrohistiocytic type, like in this case, which can mimic a HCC or a cholangiocarcinoma, and the other type is a lymphoplasmacytic type, which is more commonly seen as a diffuse infiltrative mass, just like hilar cholangiocarcinoma. Another more common imaging differential is this classical intrahepatic cholangiocarcinoma. When centrally located, this is associated with significant upstream biliary radical dilatation. On axial images, you can see this mass as heterogeneously hyperintense on T2 weighted images and hypointense on T1 weighted images. And the upstream biliary radicals may also sometimes contain blood. So this hemobilia may be seen as bright signal on T1 weighted images. They usually show marked diffusion restriction. And on post-contrast images, the intrahepatic cholangiocarcinoma in a classical case shows irregular peripheral rim-like enhancement, which progressively increases in the subsequent venous phase images. So typically, there is a rim enhancement with progressive and delayed enhancement in the later phases. There is classical IHPB dilatation distal to the tumor, and there may be capsular retraction, especially when the tumor is subcapsular in origin. Like in this case, this intrahepatic cholangiocarcinoma is a subcapsular tumor. So because of the dense fibrotic stroma, there is a marked capsular retraction. And then on post-contrast images, there is a rim-like enhancement, which is progressing towards the center. In the delayed hepatobiliary phase images, there is a classical central retention of contrast with peripheral washout. Because the active tumor cells are in the periphery, so they are non-hepatocyte containing tumor part, so it shows washout. While the central stroma is showing contrast retention because we are using multi-hands, which has 95% extracellular component, so that is basically responsible for this central contrast retention. If we have any 100% hepatocyte secreting contrast at some point of time, it will not have probably this kind of picture. So this completes the first case capsule of hypoenhancing liver masses. Now let us move on to the second case capsule. This is a young male, 27-year-old, with history of nausea, weight loss, and poor appetite for 2 months, and ultrasound revealed liver lesions. Now this is a very interesting case. You can see the liver is enlarged, and there are these ill-defined lesions which have some targetoid morphology at a few places. There are other coalescent lesions also. There is heterogeneity. There are a few patchy areas of T2 hypointensity which may represent some hemorrhage. You can see some flattening of capsule here. On axial sections, you can see there are numerous ill-defined lesions throughout the liver parenchyma, some coalescent, some discrete, and there is a targetoid morphology at some places, peripheral hyperintensity, central hyperintensity. On T1 weighted images in an opposed phase, there is no definite fat, but they are distributed lesions throughout the liver. Now the diffusion images are quite marked in this case. You can see that there are extensively distributed lesions in both lobes of liver, marked diffusion hyperintensity. On ADC images, these lesions are showing hypointense signal. So this picture goes in a bit contradicting the diagnosis in this particular case if you are still thinking about the entity. On post-contrast images, you can see that there is a heterogeneous enhancement of the lesion, which is more in the peripheral part in the initial phase, and then there is some progression of contrast in the later phases. These are the 5-minute venous phase images. This is the portal vein, not the bile duct. The portal vein is relatively thin. And you can see that the lesions are progressively enhancing. There is still some hypoenhancing part in the lesion, which are probably because of necrosis. So with this imaging picture, you can think of metastasis, diffuse infiltrative hepatocholecystoma, and hepatic epithelioid hemangioendothelioma. So we also thought of these imaging differentials, and then the lab tumor markers were done. The AFP, PIVCA, CA19-9, CEA, chromogranin, all were normal. So this goes not in favor of metastasis or a diffuse infiltrative malignancy. So hepatic epithelioid hemangioendothelioma remains one of the very important differential in this. And when you look at the 2-hour delayed hepatobiliary phase images, you can see that most of the lesions are retaining contrast, and this necrotic component is rather hyper-enhancing, again because of the extracellular component of the multi-hands. So there is no washout as one would expect in a case of metastasis or a diffuse infiltrative malignancy. So this was proved to be a case of hepatic epithelioid hemangioendothelioma. Now, there were some unusual features in the form of ADC hypointense signal in this case. And the histopath, which was done in this patient, showed high KI activity. So this was going towards malignancy. Now, this particular entity is a vascular tumor arising in the liver. It classically has maze-like appearance of lesions. There is this classical lollipop sign, which is a combination of well-defined tumor with abruptly cut off hepatic vein. This is the stick and this is the candy. And sometimes you can see this kind of target sign with a stratified pattern. So there are different kind of patterns of this entity. There may be nodular pattern, a locally coalescent pattern, or a diffusely coalescent pattern. So, or a mix of these patterns are seen in most of the cases. Now, the size of lesion is also important because if there are smaller size lesions, then lollipop sign, target sign are more commonly seen, while in larger size lesions, the capsular attraction and vascular involvement is more. Biologically, they behave between angiosarcoma and hemangioma, and in hepatic epithelioid hemangioendothelioma also, there are different kind of biological behavior even in this particular entity. So there may be some extrahepatic lesions which may simultaneously be found in some of the patients. So in this case, again going back to our case, there were multiple enlarged lymph nodes in the periportal and pancreaticoduodenal region, and these nodes had heterogeneous enhancement as well as heterogeneous diffusion restriction. So they were considered to be part of the disease, and this was considered to be a malignant hepatic epithelioid hemangioendothelioma with nodal involvement. Even a next generation sequencing was also performed in this case, which further confirmed the diagnosis because it's important for further management and follow-up of the patient. Just looking at a companion case, just to complete the spectrum, this is the elderly male with abdominal pain and malaise without any fever or jaundice. On CT images, we can see that there is a large mass involving almost entire right lobe with multiple enhancing areas on the arterial face. There are large necrotic hypoenhancing areas as well. And a PET CT was performed in which there was high FDG avidity in both enhancing and non-enhancing components. So it's a highly aggressive tumor with so much FDG avidity. There are few other satellite lesions in the remaining liver parenchyma. So the patient also had a MR scan, which was done just 2 months back, which showed that tumor was significantly small at that point of time. So this is a very aggressive tumor, and at that time there were no satellite nodules in the remaining liver as well. So this was a case of hepatic angiosarcoma, which is the most common malignant mesenchymal tumor of liver, and we keep seeing angiosarcoma once in a while. It's not that uncommon. Usually it is seen in elderly male, maybe associated with some carcinogens like thorotrast, vinyl chloride, arsenic. It may complicate by having tumor rupture and peritoneal hemorrhage. On imaging, there may be early heterogeneous enhancement with progressive filling. And there are different kind of growth patterns in angiosarcoma also, just like hepatic epithelioid hemangioendothelioma. There may be multiple nodules, there may be a large dominant mass, a mixed pattern, or a diffusely infiltrating micronodular tumor. So sometimes they are quite confusing, and it may be not easy to differentiate one entity from the other, especially malignant hepatic hemangioendothelioma versus angiosarcoma. And there have been multiple articles which have studied any differentiating features. So one of these important article I just came across. So it says that angiosarcoma has a slow in and slow out centripetal enhancement, while epithelioid hemangioendothelioma shows fast in and slow out centripetal enhancement. And the halo sign, pseudocapsule, lollipop, and capsule retraction are more common in hemangioendothelioma than with angiosarcoma, maybe because of the slow growth of the tumor, while in angiosarcoma it's so rapidly growing that there is no time for capsule retraction. Another companion case, another elderly male with weakness and weight loss. And this is another case of hepatic angiosarcoma, which has occurred in a non-cirrhotic liver background. So we actually misdiagnosed this case as HCC, because in elderly male, HCC is also pretty common as a hypervascular mass. But on histopath, after doing a left hepatectomy, it came out as angiosarcoma. And then when we looked back at the case, and when you see these MIP images, you do see these very prominent vessels within the mass and large necrotic areas, which are a bit disproportionate to the kind of well-defined mass. So in retrospection, this does fits in a case of hepatic angiosarcoma. Now that finishes the second case capsule of hypervascular liver lesions. Now coming to the third case capsule, this is a 63-year-old lady who presented with painless, progressively enlarging palpable mass in right upper abdomen for last 10 months. And there was no significant history, no history of vomiting, jaundice, any abdominal distension, weight loss. Upon examination, just a vague mass was palpable. Otherwise, there was no pain. Lab investigations were also almost normal, and remaining blood counts were also normal. So just liver mass without any other significant finding on clinical examination. So contrary to the clinical examination, on imaging, you can see that almost entire liver, except for a small part of right lobe, is replaced by this alter signal intensity masses. And a component of mass is well defined rounded mass-like, and this component is diffusely infiltrating kind of component in the left lobe. On axial images also, you can see that this is a more well-defined kind of mass, and these are diffusely infiltrating kind of lesions. So these are showing quite hyper-intense signal on T2-weighted images. On T1, they were hypo-intense. On post-contrast images, you can see this heterogeneous enhancement more in the periphery, and this infiltrative component is also showing some rim-like peripheral enhancement. On delayed hepatobiliary phase images, you can see almost complete filling in of the lesions except for some necrotic areas which are not showing any enhancement. So this is quite a weird kind of morphology on contrast enhancement, as well as such a disproportionate imaging and clinical picture. So a very important point at this juncture is to understand that the delayed hepatobiliary phase enhancement after giving multi-hands may be there in hepatocyte containing tumors like FNH, maybe there in tumors with dense fibrotic stroma like cholangioCA, and also maybe there in tumors with cystic component, again because of the extracellular component of contrast. So with this in mind, you can probably think that this is definitely not looking like hepatocyte containing tumor or a tumor with dense fibrotic stroma on T2-weighted images. So this may be a tumor with cystic component, which may appear like solid component on other images. So biopsy was done, which revealed it to be a case of mesenchymal hematoma. Now, these mesenchymal hematoma are classically tumors of childhood, but they do present in adults, and the presentation is often quite unusual and atypical in adults. These are often considered a developmental anomaly rather than a true neoplasm. So the prognosis is good in these patients. Sometimes in childhood, in children, they may be even detected prenatally or in neonatal period as a palpable abdominal mass. The peak age of presentation is about 10 months. And on imaging, cystic lesions are the commonest presentation, especially in childhood. However, a significant portion may present as solid mass or combined solid cystic form, like in this particular case. There are differences in clinical presentation as well as imaging picture of childhood and adult mesenchymal hematoma, which we have tried to summarize in this table. The median age of presentation in a childhood MHL is about 10 months, while in adult maybe about 40 years. In childhood, there is more male predominance, while in adulthood, there is more female predominance. The symptomatology is variable in childhood, maybe asymptomatic or sometimes symptomatic. But in adults, usually it is not very symptomatic. The liver involvement is more in right lobe in children, while in adults, it may be anything. The tumor is mostly cystic in children, but variable in adults. Histologically, the adult MHL may show some amount of fibrosis. Prognosis is good in both, but in adults, there may be rarely some malignant transformation, and there are various associated anomaly in childhood mesenchymal hematoma, usually not with adults. Another companion case, now once we have seen adult mesenchymal hematoma, we have seen few more in recent time. So this is another histopath proven case of adult mesenchymal hematoma. This was again an incidental detection of liver lesion, non-cirrhotic liver, a complex looking mass with some exophytic component. There is no fat. There is diffusion hyperintensity. So with this kind of imaging appearance, we had thought of a sarcoma or a cholangiocarcinoma. And because of that, we had advised for a histopath. But on post-contrast images, you can see a rim-like enhancement, and then there is some progressive enhancement on the subsequent images. But it came out again as an adult mesenchymal hematoma. Another companion case. Now, here we are going to see a childhood lesion, a 10-month-old male child who came to our OPD department with complaint of abdominal distension, recurrent episodes of vomiting, irritability, and failure to thrive. On examination, the child had respiratory distress and a large palpable abdominal mass. So in children, whenever there is a large abdominal mass, it becomes quite symptomatic because the space is so less. Otherwise, the blood test and LFTs were normal. And the alpha-fetoprotein levels were about 10,000. Now, contrast enhanced CT scan was performed for this patient. On the non-contrast images, you can see that there is a large mass which was involving almost the entire right side of abdominal cavity. This is a liver which is spaced superiorly. This is a GB. And inside the mass, we could see this prominent vessel, which was giving rise to multiple branches. But otherwise, the mass was not very hypervascular on early post-contrast images. There was a progressive kind of enhancement. And these are the MINIP images actually, just to show that there was a hypoenhancing vessel within the center of the mass, which was reaching till the inferior aspect of caudate lobe of liver. So with this imaging appearance and high AFP level, there was a strong clinical suspicion of hepatoblastoma. However, the imaging pictures were not very classical of hepatoblastoma because the early post-contrast images did not show any significant early enhancement apart from those enhancing vessels within the mass. Still, hepatoblastoma was a very important consideration in this case. And also the mass is almost entirely exophytic, and one could not actually see the attachment of the mass with liver. So the origin was also uncertain. So because of so much uncertainty in the origin and the morphology of the lesion, the child underwent resection of the mass. And at the time of surgery, the entire lesion just popped out, and it was just attached with the undersurface of caudate lobe with this pedicle. And it came out as a case of stromal predominant mesenchymal hematoma of liver. Now, this stromal predominant tumor, this appears as a solid tumor on imaging. It very closely simulates hepatoblastoma, and the AFP levels may be high in this variety of mesenchymal hematoma because of the hepatocytes which it contains. And the hepatoblastoma may show AFP levels in thousands or lakhs, even much more than the AFP levels in such a large tumor. So also, there may be some other symptoms with hepatoblastoma. There may be visualization symptoms, thrombosis, osteopenia, or sometimes there may be some calcifications. Still, that always remains in as one of the close differential because it is much more common entity than a stromal mesenchymal hematoma. But it is just to show that this is appearance of MHL, which can confuse with hepatoblastoma. And actually, when I look back at literature, I saw multiple such case reports in which there was a exophytic stromal predominant MHL arising from liver just in this location. And I'm just thinking that if there are some precursor cells around the caudate vein, because this thing was not enhancing on arterial phase, and this was always like a hypo-enhancing structure in arterial as well as in venous phases. So to me, it appears like a thrombosed caudate vein. And it is exactly attaching to the site of caudate lobe IVC junction. So I think there may be some precursors around the caudate vein which give rise to this kind of MHL. So it still has to be seen, and some further case reports, case series, or research has to be done in this regard. Okay, so that finishes our third case capsule of mesenchymal hematoma. Now moving on, middle-aged lady with abdominal pain, and the outside ultrasound and CT suspected a GB mass. So this patient came to us from outside country with a suspicion of GB mass, and ultrasound picture shows that there is some hyperechoic area which is very close to the GB, but otherwise the GB wall was not seen to be involved. So with this we did MRI. And on MRI, you can see on T2 weighted images, there is mild hyperintensity in segment 5 abutting gallbladder. On fat set, there is signal drop. On diffusion, this is the GB, so the lesion itself is not showing any diffusion restriction. And on in-phase and opposed phase, there is marked signal drop on opposed phase compared to in-phase. So with this imaging picture, one can think of focal fat infiltration in the region of GB fossa, which is quite common. And on post-contrast images, you can see that there is, excuse me, I'll just see what is going on. So on post-contrast images, you can see that there is no significant enhancement on these images. And there is mild enhancement in the periphery of the lesion. So with this, it was not really clear whether this is a fat-containing lesion or really, excuse me, can I just pause for a minute?
Yes, sure, madam.
Sorry, some repair was going on. So on these images, it was not clear whether this is really a arterial phase enhancing lesion or not, although there is hypoenhancement in these venous phase images. So here I just want to make a point. Then whenever a lesion is different from the background liver parenchyma on pre-contrast T1 weighted images, then we have to see subtracted images. Now we are very well aware of the ablated lesion because they are hyper intense on T1 weighted images. So we always do subtraction images in post-ablation lesions. But even when the lesion is hypointense compared to the remaining liver parenchyma, we have to do subtraction. And when we see subtracted images in this particular case, we can see that there was significant arterial phase hyperenhancement. So with these images, now we can confidently make a diagnosis of hepatic adenoma rather than a focal fat infiltration. Also on 5-minute delayed venous phase images, you can see this nodular configuration which is projecting here, just like an exophytic component of a liver lesion. These are the 2-hour hepatobiliary phase images in which you can see marked hypoenhancement of lesion on these images. So this was a hepatocellular adenoma. As we all know, this is a lesion more commonly seen in middle-aged women. There is increased risk when the person is taking estrogen or androgen-containing steroids, type 1 glycogen storage disease, diabetes, or any congenital or acquired abnormalities of the hepatic vasculature. Now, adenoma have been classified initially in 4 different subtypes, the inflammatory, HNF1-alpha, beta-catenin, and undifferentiated. And later on, 2 more subtypes were added, the sonic hedgehog and the mixed variety. The inflammatory are the commonest, and they are usually seen in women and associated with inflammatory conditions like obesity, diabetes, and hepatic steatosis. They have a very high risk for hemorrhage. HNF1-alpha inactivated adenoma are the good kind of adenoma. They are the second commonest. They are seen in women who use OCPs. Fat is the hallmark of this subtype. And there is a low risk for hemorrhage as well as minimal risk for malignant transformation, especially with smaller HNF1-alpha adenomas. The beta-catenin is the worst type. It is more in men and has the highest risk of malignant transformation. Sonic hedgehog, again, is like inflammatory. It is also associated with obesity, hepatic steatosis, and has a very high risk for hemorrhage. Now, when we see adenoma, it is very important to differentiate it from FNH, and for that, we try to see the enhancement pattern on venous phase images. Most of the HNF1-alpha and beta-catenin adenoma show washout compared to FNH, which shows persistent enhancement. However, the inflammatory subtype may show persistent enhancement, and because the inflammatory subtype are the commonest kind of adenoma, so the venous phase hypoenhancement is not always very useful in all the cases of adenoma. However, the delayed hepatobiliary phase hypoenhancement has a pretty high specificity to diagnose hepatic adenoma versus FNH in 95% cases. Only some cases of beta-catenin and very few cases of inflammatory may show high hepatobiliary phase signal. Hepatic adenomyosis is another entity which is not related to steroid medication, may be equally present in both men and women, and inflammatory HNF1-alpha as well as beta-catenin adenoma may be present in the case of adenomatosis. Why a person is concerned about adenoma much more than FNH? Because of the risk of bleeding and malignant transformation. So bleeding may be seen in about a quarter of patients, and the important factors to consider for bleeding are OCPs and obesity, because they are associated with inflammatory and sonic hedgehog. The lesion factors are size more than 3.5 centimeter, lesion in left lateral segment, exophytic nature, visible arteries in lesion, and a sonic hedgehog or an inflammatory variant. Malignant transformation is less common, seen in about 4 to 8% people. The lesion more than 5 centimeter, beta-catenin or a mixed subtype are more commonly associated with malignant transformation. On imaging, if one sees growth of the lesion or vascular invasion, then one should always suspect a malignant transformation in a case of adenoma. Now, whenever we talk about adenoma, we have to talk about FNH, otherwise it doesn't do justice with the case. So this is a case of classical FNH in a young female, and these are the hepatobiliary phase images. So whenever you see these kind of hepatobiliary phase images, these are spotter images. There is no other diagnosis apart from FNH. Whenever there is this kind of lobulated popcorn kind of lesion, which shows hyperenhancement on hepatobiliary phase images. It is also known as stealth lesion because it merges with the background liver parenchyma on T1 and T2 weighted images. There may be some diffusion hyperintensity, and there is marked hyperenhancement on arterial phase images with persistent enhancement. The scar may enhance, and it is although very notoriously associated with FNH, but one should remember that only about 30 to 40% FNH show a scar, the remaining do not, and absence of a scar does not preclude a diagnosis of FNH. Now, hepatobiliary phase hyperintense lesions, the most common diagnosis is FNH and FNH-like lesions. However, as we discussed, some cholangiocarcinomas also show and some metastasis because of their fibrotic stroma or a central cystic component. And also in cirrhotic patients, a small proportion of well-differentiated HCCs may show hepatobiliary phase hyperintensity in about 9 to 14% cases because of actively functioning hepatocytes. So that finishes our fourth case capsule of hepatic adenoma. Now moving on to the fifth case capsule. This was a middle-aged male patient who presented with abdominal pain and jaundice. Now these are the MRCP pictures. The patient has presented with jaundice and the referring physician is always excited to see the MRCP pictures. So in MRCP pictures, we can see that this is the right anterior sectoral duct, this is the right posterior sectoral duct, and we don't see anything on the left side. This is the stomach. So this is the standard oblique AP kind of projection, and we don't see the left hepatic duct. This is the CBD, which is seen here. On axial images, we can see that the liver is slightly irregular at some places. There is this rounded lesion in the left lateral segment, almost same signal as liver on T2 weighted images. On T1, there is slight hyperintensity, mild hyperintensity. And there is this contiguous signal alteration extending along the left hepatic duct, which is totally obliterating the duct. This is the portal vein, which is separately seen. It's not really a venous thrombus, it's a portal vein. On post-contrast images, you can see that there is some arterial phase enhancement in the parenchymal lesion. There is definite arterial phase enhancement in the intraductal component. And there is heterogeneous enhancement on the venous phase images. And there is some washout in the parenchymal component. So with this imaging appearance, now also you can see the coronal images. You can see that this component in the CHD, which was seen as filling defect on MRCP images. This was the right anterior and this is the right posterior, which will just go here after taking almost a loop. And on post-contrast coronal delayed images, you can nicely see this parenchymal component and a contiguous extension of this mass within the left hepatic duct. So with this imaging picture, you can think of cholangiocarcinoma or HCC. Now, because there was this intraductal extension, it is absolutely justified to think about cholangiocarcinoma. But if you look at the parenchymal component, it shows washout on venous phase images. And if you look at the intraductal component, you can see some duct wall here, which is still not involved. So this is a component which is projecting within the lumen rather than actually infiltrating this part of duct wall. So with this in mind, the patient underwent a left hepatectomy and the tumor was seen as a case of HCC, as you can see on these slides. So intraductal extension of HCC is not very uncommon. We do keep seeing these kind of cases. There are a few features which help to differentiate between intraductal HCC versus cholangiocarcinoma. If you see intradural polypoidal lesions rather than infiltrating kind of lesions, without any apparent fibrosis or thickening of duct wall, no significant constriction of the ducts, rather the ducts may be expanded into a fusiform shape. The intraductal tumor thrombi are hypervascular, like in this case, you saw arterial enhancement of the intraductal tumor. Sometimes you may see intraluminal fragments or blood clots, and if there is background liver cirrhosis, then these are the features which indicate towards a intraductal HCC rather than a cholangiocarcinoma. So just to complete the spectrum, this is a case of cholangiocarcinoma. You can see this irregular rim-like enhancement. The enhancement of parenchymal component is also very important to differentiate between HCC and cholangiocarcinoma. And there was this infiltrating kind of mass in the adjacent duct. And if you see the enhancement of the parenchymal component, it is quite specific for a cholangiocarcinoma, the heterogeneous peripheral kind of enhancement with persistent enhancement on the venous phase images. Now, cholangiocarcinoma, as we know, is malignant tumor arising from biliary epithelium distal to the second order bile ducts. This may be a large duct type or a small duct type, and typically there is enhancement.
अरे मैं हाथ धो रहा हूँ बेटा, रुक जा, उसको मैं हाथ धो रहा हूँ बेटी, अरे तो
Okay. So this is another type of carcinoma which we also saw some time back, subcapsular cholangiocarcinoma presented with capsular retraction.
Okay.
Now moving on to the next case, a 45-year-old lady with abdominal pain and lung. Yeah. So in this, we can see that there is a large lobulated mass in the left lobe of liver. And these are the contrast-enhanced CT images. In the arterial phase, we can see some enhancing arteries within the periphery of the mass. And the center of mass is necrotic and relatively hypoenhancing. There is heterogeneous enhancement more at the periphery. So with this CT picture, a MR was also performed. On MR, we can see that the lesion was quite hyperintense on T2 weighted images and hypointense on T1 weighted images with this targetoid kind of morphology. The central part of tumor was of higher signal than the peripheral part. And there were few small satellite nodules in the remaining liver parenchyma, and there was this upstream biliary prominence. On post-contrast MR images, you can see these visible arteries in the periphery of the mass. There is marked heterogeneous enhancement in the periphery. There is this corona enhancement in the adjacent liver. And on delayed venous phase images, you can see that there is washout from the periphery and there is contrast enhancement in the inner part of the lesion, with center is still hypoenhancing. So when there is this kind of of a liver mass, there is always a suspicion of biphenotypic primary liver carcinoma. Now, in these kind of cases, there are few features which favor cholangiocarcinoma and few features which favor HCC. Like in this case, the mass has a lobulated shape, there is a peripheral rim enhancement and presence of bile duct dilatation, which is a feature favoring cholangiocarcinoma. While the heterogeneous enhancement, visible arteries, washout pattern are features favoring HCC. So these tumors are relatively bad kind of tumors. The treatment is surgical. The risk of recurrence is quite high. And the predictors of recurrence are male sex, macrovascular invasion, and lymph node metastasis. Another companion case, a middle-aged lady with abdominal lung. And there is this large mass arising in right lobe of liver with a central scar. The liver is not very cirrhotic. And you can see heterogeneous enhancement with few radiating septae and then this scar. So this is a classical case of fibrolamellar HCC, which is more common in young patient, not related to cirrhosis with normal AFP levels. On imaging, there is a large mass with peripheral enhancement, central scar. Calcifications may be seen and there is a high incidence of lymph node involvement. So that finishes our fifth case capsule of hypervascular liver masses, and especially the intraductal extension of liver tumors. Now moving on, the sixth case capsule, a middle-aged female presenting with vague abdominal discomfort and a liver mass was detected on ultrasound. So on these contrast-enhanced CT images, you can see that there is a very well-defined liver mass arising in segment 5-6 of right lobe of liver. And this has a exophytic component. There is significant enhancement on the arterial phase images. The mass is quite heteroenhancing necrotic or cystic area. On the venous phase images, the hypoenhancing areas are remaining as such, and the hyperenhancing area which was seen previously is almost mildly hypoenhancing. So with this imaging picture, it is very valid to think about a diagnosis of HCC. That's the commonest tumor, which is hypervascular in even in a non-cirrhotic liver. But then when you see presence of these cystic or necrotic, so much cystic non-enhancing areas, one should always suspect a diagnosis of NET also. And on histopath, this came out as NET. On DOTA PET, this showed significant DOTA activity. in the lesion. There was no other DOTA-avid lesion in the remaining body. So this was a primary liver NET. Now, primary liver NET are not very common. One needs to document absence of lesions at other sites, especially small intestine, pancreas, lung. These are more common in middle-aged men and women. And classically, they have cystic areas on imaging, and they have a high uptake on DOTA-PET. Another case of liver NET. So whenever you see these kind of lobulated lesions with cystic areas, especially nowadays with the high PPI intake in general population, the incidence of NET is usually rising. They are marked diffusion hyperintense. And on post-contrast images, the cystic areas show hypo enhancement, while the remaining solid component shows hyper enhancement. This is the classical NET met. In this case, it was arising from a tumor in the mesentery, and they were hypervascular on arterial phase images with iso-enhancing on venous phase images. So this was the primary tumor, which is also seen on PET images. So it is said that the pancreatic origin NET met typically origin NET mets show portal venous washout. And sometimes the mets may show a fluid level, which is quite suggestive of NET mets. On PET CT, if they are poorly differentiated, they show a high FDG avidity, while if they are well differentiated, they show a high DOTA avidity. So moving on to the next case capsule, the last case capsule, actually. This was a young male with complaint of abdominal pain without any fever or jaundice. So vague abdominal symptoms. And on imaging, you can see that there are these multiple ill-defined T2 hyperintense lesions with diffusion hyperintensity in the right lobe of liver. There was some vague abdominal pain, and the patient, I am just holding the other details at this point of time. But then we did a subsequent scan 6 weeks later, and then we can see that the initial areas of signal alteration have partly resolved, and there are a few new areas of signal alteration in the remaining part. So this was a classical case of visceral larva migrans, which is a migration of second stage larvae of nematodes through the tissue of human viscera, and usually it is caused by Toxocara canis and catty, and uncommonly there are a few other pathogens. On imaging, one can see single or multiple oval or elongated hyperattenuating small or scattered coalescing lesions, mostly in portal venous phases, more in the periphery of liver and along the portal vein branches. And classically, one needs to differentiate it from fasciola. The fasciola and VLM show very similar kind of pattern on imaging. Fasciola is more subcapsular, while VLM is more central because of portal origin of these lesions. And also the complications are more pertaining to the portal vein in VLM compared to fasciola, which has more biliary complications. So that finishes our case discussions. If there is still time, I can take on the quiz cases. Akshay, should I move on to the quiz cases? Or should we just close it?
So, do you have enough for another session? Because if you do, then we can just do another session. But if you think that 10 more, then we
quiz cases are quite simple. We can just fly through them.
Okay, fine.
Okay. So moving on to the quiz cases. This is a middle-aged man with presenting of complaint of abdominal pain and fever. And these are the MR pictures. You can see this is a classical spotter of recurrent pyogenic cholangitis. There are these irregular areas of stricture, dilatation, interductal pigmented calculi, classically hyperintense on T1 weighted images. So I'll just skip the literature part. Another case, a 64-year-old male with abdominal pain and jaundice. And these are the MRCP images. You can see usually dilated MPD, usually dilated CBD, and wide ampulla at this point. So this is a classical case of IPMN, the main duct type. And there are few features of main duct IPMN which indicate malignancy. Then this has to be remembered by the examiner. The IPMN may also present as a mixed variant, small duct and main duct mixed variant, like in this case. Other case, elderly lady with non-specific abdominal complaints, and these are again the spotter somebody can diagnose. So This is a case of serous cystadenoma of pancreas with classical central scar and some radiating septic. This is a prospective liver donor on imaging. This is appearance which one should always remember, a left-sided gallbladder in donor screening. This is associated with abnormal portal vein configuration, a type E portal vein. Another patient with type E portal vein, which was incidentally seen on MRCP of some other indication. A middle-aged man with mild abdominal pain, and this is the MRCP, which shows duplication of gallbladder. One of the gallbladder may have some sludge or some retained bile because the drainage may not be sufficient. So, another middle-aged woman with abdominal pain and bloating, and this is a classical appearance of xanthograndomatous cholecystitis. A young man with recurrent episodes of abdominal pain, and on MRCP images, you can see that the CBD is dilated, and there's a PD. Part of pancreatic duct is encircling around the duodenum, and this is a case of annular pancreas. A middle-aged lady presenting with short history of upper abdominal pain, and this is a spotter for a biliary cystadenoma. This is classically seen in segment 4 of liver, middle-aged woman. These kind of septations, not ready daughter cyst, spotter for cystadenoma. Known as MCN now with altered nomenclature. Another counterpart of cystadenoma or MCN is IPNB, in which the biliary radicals are dilated and there are intraductal soft tissue which may show diffusion hyperintensity. There may be associated cholangitis in the remaining liver, but there may be contrast enhancement in the intraductal component. So there are a lot of differences between MCN and IPNB. And this is probably the last spotter, a young male from Central Asia. This should be known, not to misdiagnose. These feathery calcifications, infiltrative kind of lesion, a person coming from Russia or Central Asia, classical alveolar echinococcus is not very uncommon to see. So that's it. So the take-home message is to correlate all the cases with disease history, tumor markers, LFT, and the most important thing is one should have a problem-solving attitude. Instead of writing, please correlate clinically, which has been attached sarcastically with radiology reports. The radiologist should try best to correlate themselves. So that's it. Thank you for this journey of learning together. Thank you, Akshay.
Thank you so much, madam. As usual, just phenomenal cases. And I just always marvel at the ease at which you end up diagnosing many of them, even on our WhatsApp groups. So we have a WhatsApp group where we show some difficult cases with each other. And it's always just so comfortably diagnosing them. So there are some questions, madam. So this is from an anonymous user on the first hepatic endothelioma case, hemangiendothelioma, I think he means. He or she is asking whether the enhancement pattern, would it match the blood pool with hepatic endothelioma?
Not always, because it is not really like hemangioma. In hemangioma, it does match with the blood pool, but hemangioendothelioma has a lot of heterogeneity. It has intralesional cystic areas, hemorrhages, fibrosis, so it does not always match blood pool. But it should not show washout. So there is usually a progressive enhancement, not a washout.
Got it. Another anonymous attendee asking, is it possible to make a single diagnosis in such complex cases? Would you give differentials? When would you biopsy versus when would you recommend an MR or a PET in such cases?
So the tendency is to give the commonest diagnosis first. So it is more common to see unusual appearances of common lesions rather than unusual lesions in the first group. So like in the case of lymphoma, when we saw that, lymphoma case was still quite looking like lymphoma. But in case of inflammatory pseudotumor, which I showed, we had diagnosed it as a case of cholangiocarcinoma, not really as an inflammatory pseudotumor. But the idea is just to keep seeing these unusual lesions so that in future we become smarter. So when I look back at the literature of that large exophytic solid mesenchymal hematoma in that particular child, in literature there are so many such case reports described. So it is just to make us wiser so that in future when we see these kind of cases, we think about this particular entity as well, not just straightforward giving a diagnosis of hepatoblastoma and asking for chemo. At that point of time. In this case also there was a lot of discussion because the AFP was also high and the clinical team was not really convinced of non-hepatoblastoma lesions, but because of the unusual imaging findings, we kept our point and thankfully it came out as something else. But it is important to give a differential, very important to give a differential rather than one diagnosis.